Okay, so let's dive deeper into radiography in particular. So as we look at how an X-ray is generated here, we look at the X-ray tube here that sends an X-ray beam out. It interacts with the body and then is displayed on a film here. The film absorbs these rays based on the density of objects that it passes through and creates a film. So X-rays can either, depending on if it's through air, it will almost pass straight through. If there's a device or object in the way, then it will be deviated or stopped and lose energy as it goes through. And so based on that, we create a black and white film that's generated on, these days, a digital format that allows us to examine the body. So really, we're looking at principles of radiodensity, or the physical properties that an object has as it absorbs the X-ray beam. So depending on the composition of the material and thickness of the material, it'll generate a picture on the film. So here we're talking about radiographic density. This is the amount of blackening on the radiograph. So there's a inverse relationship between what we'll call radiodensity and radiographic density. So if we have increased radiodensity, we have decreased radiographic density and creates a white portion on the image, on the film. If we have decreased radiodensity and increased radiographic density, it creates a black portion to the film. So depending on the amount of density here, we can create a good image on X-ray film. So to clarify this a little bit more, if you look at the radiolucency, which is the blackness, or the radio-opaqueness is the white portion of the film, you'll see those terms used interchangeably, particularly on radiographic reports. Air comes out very black because it has increased radiographic density, whereas metal shows up to be very white or almost opaque because of the amount of density here. So like metal artifacts, bullets, those type of things come out as very white. Bone comes out a very light gray because it does allow some of this radiodensity to pass through, but it's absorbed quite a bit by the bone. Whereas soft tissue, water, those things are kind of a medium, and fat's a very dark gray because it's very open and allows a lot of things to pass through. So this, if we look at the saline bag below, you see bone on the image there. You see contrast material, which we'll sometimes use with different tests. It shows up very well on radiographs. Scissors, metal objects show up very well on radiographs. So you'll see different objects and how they relate to X-rays. So keep that in mind. The main terms you really need to know is radiolucency and radio-opaqueness. Those are really the big things you'll see on imaging reports. So as we look at an X-ray image here, it's basically a basic chest X-ray. You see different portions of the bone that are more white than others. So like clavicle is a little less dense than the scapula here that you see. The heart creates a shadow there. You see air within the lungs, and you see the ribs. So you see a lot of different things as an example of these radio-opaqueness, the radiolucency. So we know that nothing is really very completely radiolucent or very or fully opaque in most cases, unless it's a foreign object. So you'll see different shades of gray and black and white on these films, and this is what makes our image that we're allows us to examine the body through a radiograph. So the technique we're going to really look at is, so Really, we don't look at images usually until after a history or screening exam is done. So don't let that image cloud your history or your examination findings. We want to get the necessary views, but not all, but the necessary views, usually a minimum of 2 at mutually perpendicular angles. So we want to get a good image, because these are 2D images, we want to get a good representation of the body in almost a 3D orientation by utilizing 2 perpendicular angles of imaging here. Make sure that we got the entire area included on the radiograph. You'll see anatomic markers and patient IDs on these films. So a lot of times there's an anatomic marker that tells you which is right and left. Make sure we're getting good quality images. So sometimes it's underpenetrated or overpenetrated, which makes them too light or too dark to read. So we don't want to accept poor films if you are in charge of that at some point. Radiation protection, make sure that the patient is protected. The reproductive organs, breast, thyroid, those type of organs are protected from the radiation as much as possible. And then sometimes we'll use contrast material, particularly with an arthrogram or a myelogram. They can use different contrast materials here that'll show up well on these x-rays. So as we assess these x-rays, really we're going to look at the evaluation. So you see up here in the right, or on our screen on the left side, the R, which indicates that is the patient right. So you're going to look at the patient as if they're facing you at all times. So when we look at radiographs, when we look at even MRIs, they'll be oriented this way. So first thing we're going to look at is alignment. We're going to look at bone density. We're going to look at cartilage spaces, and then we're going to look at soft tissues. So we kind of work our way around the bones and bone density, and then the cartilage, and then the soft tissues. So we call this the ABCs of radiographic evaluation. So alignment, bone density, cartilage, and then soft tissues. So first thing we look at is the alignment here. So if you we're looking at these images here. See the humeral head and a glenoid. So if you look at the from the front here, looking at AP direction, you see a humeral head that's not quite setting in the glenoid very well. And then if you get the perpendicular view, you see that this is a dislocation. So we know something's not quite right in one view, but you take a perpendicular view and you definitely will see the displacement of the humeral head here. So we're going to look at the size of the bone, the shape and contour. So you already see a pretty good divot here with a Hill-Sachs lesion. And you always want to look at the alignment compared to these other bones and make sure you've got good quality image here. So we can see here there's really no fractures here. We don't see any lines here or anything like that. We've got a good outline of the bone. The humeral head setting kind of in front of the glenoid at this portion, because you see the overlap of the humeral head on the glenoid here. So we know there's something going on here in this view. And then we look here and you see the humeral head sitting in front of the glenoid with that Hill-Sachs lesion. So really we want to look at all these views, look at your alignment, the bone density here, cartilage spaces. In fact here, you see an overlap here, so you know something's going on with the cartilage. And then soft tissues, so because we're kind of cut out on this view, but you see the soft tissues here, you don't see anything really major at this point. Then looking at bone density, so if you compare distinct shades of gray, so if we look at these femurs here, you see a nice white bone here with good density. Here you see a little shadow, so the bone density is not quite as intact here. It's not as dense as the opposite side. So that may be indicative of a condition, or could be indicative of like osteoporosis. So be looking at those and compare the cortical bone here, the nice white, brighter white, which is thicker, versus the cancellous bone in the middle here. So you can see that there's the marrow is a little different here. And then any type of sclerosis or anything like that. Sclerosis is this white film that you'll see here of two bones with decreased joint space. We'll look at that a little bit more when we start to talk about osteoarthritis. So here we see this osteoarthritis. I got nice open joint spaces here. Like I say, you don't see a lot of little lack of bone density here. Cortical bone here, nice and white. Shadows here. The soft tissues, nothing there really going on here. And then the so you see the, like I say, cartilage spaces there. You see a little bit of a fracture here where it's been decreased here. Compared to over here, you see a osteoarthritis, decreased joint space, sclerotic bone, which is this nice bright white cartilage here that's become, this is what normal cartilage should look like. And here you see it's significantly brighter and decreased joint space here. So this would be the sclerotic bone that we're looking at. So cartilage space, like I say, the joint space definitely decreased in these images here. So we know that there's probably more of an osteoarthritis type situation going on, possibly. We have to compare that with our clinical history and clinical exam. Looking for symmetry here. So if you compare these, what's the symmetry look like? What's the bone density look like? And then in growth plates, in some cases, you'll need to be looking at those as well, making sure those are intact and in good shape. We don't want to see disruptions or separations of those. Okay, so once again, normal knee, narrow joint space. You see more lucency here, so it's like I say, it's a little darker, more of a shadowy type of space here because there's not a lot of loading going through it, so it's not as dense here. Whereas here you see more of a bone spur, you see decreased joint space, you see more loading going through this part, so it's brighter, and you don't see the lucency on this side of the femur here on the medial compartment. So just be looking at those top things as we get to looking more at imaging. Then we look at soft tissue. So looking, like I say, looking out here, look at this gross musculature. You can see the shadows of the soft tissue. May see fat pads, those type things in this case. In this case, we see a lifting of the soft tissue here. It's called a fat pad sign. So you see this soft tissue's been lifted away compared to this elbow. You don't see anything like that. You see this nice shadow right here. This is swelling. This is usually indicative of we want to start looking at radial head fractures and intra-articular fractures of the elbow with this sign. So this is what we'll call a fat pad sign, just due to increased volume and swelling here of the elbow within the capsule. You may see some periosteal lifting. Here is indicated by these little lines here, look like little tree rings in a way on the bone here. This is the periosteum lifting off of the bone here, off the cortical bone. So this is called periosteal elevation or lifting, which indicates that there's some pathology of the bone. You may see foreign bodies, tumors, like you see over here. Probably a possible tumor going on here. So be looking for different aspects of these in the soft tissue here. So who interprets images? So really the only people legally allowed to interpret an image is a radiologist. Even if we got films, we're not allowed to issue a diagnosis based on image that's presented to us. So even if they came with an image that showed a significant fracture that's very obvious, we're not allowed to give a diagnosis of that fracture legally. That has to be done by a radiologist or physician. So we can show that like signs and symptoms of a fracture, those type things, but we cannot issue the primary diagnosis. So any type of physician here, radiographer, those type of people are usually the ones that issue the official diagnosis with these. So you'll see ER physicians, attending physicians, even PAs, nurse practitioners, and in case some PTs, they're able to look at the image, but they're not allowed to necessarily give the full blessing of the diagnosis until the radiologist looks at it and issues that. So as you start looking at radiology reports, more often than not you'll get a report as opposed to the actual films coming from physicians. So you'll see that there's usually some sort of, tells you the type of exam, chest, this was a chest x-ray, 2 views, the date and time it was done, sometimes exam codes and exam numbers, whatever that they need to utilize for their organization. And then it'll tell you report status final, means that it was interpreted by the radiologist and issued a diagnosis. So typically we refer people for imaging based on a history or to rule out something. In this case, the patient had a cough and fever, so we wanted to get an image for that. And so it tells you that they got a front and lateral view of the chest. There's nothing to compare it to like a previous study or anything. There's no lines or tubes. Lungs tells you well inflated and clear. No evidence of pneumonia or pulmonary edema. There is no pleural effusion or pneumothorax. They start looking at the heart. In silhouette is normal. So the heart is in good position and good with no other findings. The skeleton around the bones, so they're looking at ribs, sternum, all the clavicle, all those are normal. So the impression is that there's clear lungs without evidence of pneumonia. So that's the kind of the diagnosis or impression, and no recommendations by the radiologist. Typically it's tells you who ordered it, the provider that ordered it, and the signature, or who interpreted it, and the signature of the person who did it. So, and then they'll usually give you some sort of number or somebody to contact if you have any questions about it. So that's kind of what you'll see in a radiology report. The first thing we typically look at is the impression. Then you can go back up and start looking through the report and seeing how they came to that conclusion, if there is something there. All right, so that's kind of finishes up introduction more into the radiology report and how it's developed. We'll start looking more at fractures and fracture management in the next lecture.